this session, we're going to talk about shock. So we're going to talk about the main types of shock, whether that's cardiogenic shock, whether that's hypovolemic shock, or whether it's cardiogenic shock. But first of all, we'll just give you a couple of review questions to look at and what can you remember about cardiac function. And the reason we're talking about this is because it becomes relevant when we're thinking about the cardiovascular system and some changes that occur during shock itself. So which of the following statements are correct regarding the cardiac function? Contraction and dilation of arterioles provides greater changes in blood pressure than contraction and dilation of arteries. That is obviously correct. So you get vasodilation and vasoconstriction of arterioles alters blood pressure a lot more. Large arteries consist of mainly smooth muscle, whilst arterioles have mainly elastic tissue. That's obviously incorrect. It's the other way around. So your large arteries are nice and elastic, which allows them to bulge out and recoil in following high pressure when the heart pumps, whilst your arterioles have got that smooth muscle, which allows them to contract and dilate, or contract and relax is probably a better word, to alter blood pressure. Number 3, there is steady blood flow through arterioles and capillaries, unlike arteries where blood flow is pulsatile. That's correct. Because of the recoil of arteries, that makes them pulsatile, and the frictional resistance of arterioles makes it a much smoother flow. Afterflow is the force that stretches relaxed cardiac muscle fibers. That's incorrect, obviously. Afterload is the force that must be overcome in the aorta. So the answer that's shown is actually preload, obviously. The force that stretches relaxed cardiac muscle fibers is preload. Okay, so we're going to think a little bit about hemorrhage and shock, first of all. So shock obviously occurs when the cardiovascular system fails to perfuse tissues adequately and the cells start to become hypoxic. Some tissues are a lot more resistant to shock than others. So for example, the skin can be deprived of blood flow for many hours without dying or without all the cells dying, whereas brain and cardiac tissue with their high metabolic demands start to become damaged after only a few minutes. And there are lots of different types of shock, as I've already alluded to. So you've got hypovolemic shock, and that's where you have an issue with the blood volume. So the blood volume is dropped. You've got cardiogenic shock where you've got an issue with the heart pump itself. And then you've got distributive shock, and that's where you have issues with the blood vessels. And that might be neurogenic, anaphylactic, and vasodilatory. There are lots of symptoms of shock that are shown on the right-hand side there, and these are compensatory shock mechanisms, if you like, often because of stimulation of the sympathetic nervous system, which will lead to your sweating and other things. But there are lots of symptoms, so shaking, sweating, anxiousness, dizziness, your fast heart rate, impaired vision, fatigue and weakness, and headache, amongst other things. They will all be covered later on. So we're going to go through these various types of shock now. So the first one we're going to talk about is hypovolemic shock. And this results, as would be expected, from a reduction in the plasma or the blood volume. The most obvious, of course, is from open wounds, so where you're getting blood loss, and that blood loss from arteries, obviously that appears bright red due to the oxygenated hemoglobin. And most dangerous are the ruptures, like I said, in arteries where the pressures are high and the loss is pulsatile, and therefore it's got a higher flow rate and therefore a higher flow rate to be lost. And as I said, what does this appear? Colour does it appear where it's bright red. Blood loss from veins is usually slower because there are lower pressures, of course. But when we're thinking about this, you don't always see that blood loss. So significant hemorrhage can also occur without obvious blood appearance. For example, closed fractures of the femur with large significant internal bleeding. And remembering what a closed and an open fracture is, and a closed fracture is just where the skin is intact and the fracture site is not in contact with the outside, whereas an open fracture, the skin is not intact and the fracture communicates with the external environment. So you probably know that already. You've closed and open breaks or fractures. So moving on, so like I said, it results from a reduction in plasma or blood volume, but that plasma loss can occur through several mechanisms. It doesn't necessarily have to be through blood loss from an artery, for example. It can also be due to the buildup of ascites, and this is where you're getting that buildup of fluid in the abdomen, for example, due to liver cirrhosis or significant protein deficiency and that lack of oncotic pressure and ascites buildup. It can be through skin burns where you get increased capillary permeability and results in huge amounts of plasma loss. And you may have intestinal obstructions, where a swollen intestine can collapse veins, causing an increase in your capillary filtration into the abdominal cavity. So there are other mechanisms of hypovolemic shock that don't immediately come to mind, but you've always got to be considering these. And of course, dehydration also, or significant dehydration, also reduces circulating blood volume. For example, cholera, so the diarrhea and vomiting that is induced by cholera toxin, leads to, as it enters the small intestine, it leads to water, potassium, sodium, chloride, and bicarbonate secretion and resultant diarrhea. And cholera, as you'll probably know, is an infection of the small intestine, and it comes from drinking water or eating food contaminated with feces. Some renal diseases lead to a significant water loss via the kidneys, and you'll cover that later when we talk about kidney disease. And then we've got Addison's disease, and this is where there's autoimmune destruction of the adrenal cortex. And if it's significant enough, it can lead to reductions in aldosterone and cortisol secretion. And of course, if you have a reduction in aldosterone secretion, you're not able to reabsorb your sodium as well, and therefore you're not able to reabsorb your water as well. And that can obviously lead to hypovolemia and hypotension. So if we're thinking about hypovolemic shock, we're thinking about the various stages. So how much are we losing at each stage? So I'll give you a little bit of a clue to start with. When we're looking at this table, we've got these 4 stages. Stage 1, stage 2, stage 3, stage 4, and obviously we're going mild, moderate, and severe. And fairly minor losses in blood volume doesn't or shouldn't result in shock. So 10 to 15% reduction in blood volume shouldn't result in shock. So when we're thinking about these losses, you've got, if you're at less than 15%, then your blood loss is, relatively speaking, less than 750 mils. So that's fairly minor, and hopefully you shouldn't get any significant changes or not too significant compensatory mechanisms kicking in. If we're thinking about mild, we're thinking somewhere between 750 and 1.5 litres. So you're thinking 15 to 30% blood loss, moderate 30 to 40% blood loss, so up to 2 litres lost, and more than 40% of your blood volume has been lost if you've lost about 2 litres or so, remembering that you have 5 litres of blood, of course. So let's go through each of these. If we're thinking about stage 1, I want you to predict what's going to happen. So look at, press pause, or press pause after I stop talking, then press pause. So looking at stage 1, we've got fairly insignificant loss of blood. What's going to happen to heart rate? So are they going to be, is it going to be normal, or is it going to go up, or is it going to go down? Same thing with the pulse pressure. Remember, that's the difference between a systolic and diastolic pressure. What about your respiratory rate? What about your urine volume? Is it going to be reasonably significant, or is it going to be starting to drop? And we're thinking about mental status. We're thinking about is someone having a normal mental status? Are they a little bit anxious? Are they getting agitated and confused, for example? So take a look at stage 1, make your predictions. So press pause, make your predictions, and I'll go through it. Okay, so let's have a look what's happening in stage 1. So there you go. So your heart rate should remain below 100 beats per minute. Blood pressure should be remaining fairly normal because your compensatory mechanisms will kick in and maintain that blood pressure. Therefore, your pulse pressure also should remain normal. Respiratory rate around about in the normal range, so somewhere in the 12 to 20 range. Urine volume still reasonable at more than 30 mils per hour, and your mental status should be fairly normal as well. Just to put this into context, when we're thinking about this volume of blood loss at this stage 1, have any of you donated blood? Well, if you have, they'll tend to take about 500 mils from you, and that's 10%. So that's 10% blood loss, and you don't go into shock, obviously, or hopefully you don't. It's very well tolerated. A trained athlete may notice a drop in performance, of course, because of that drop in blood volume. Okay, so now let's go on to the next one. Now we're thinking about mild. Have you had a bit of a think about these ones? Okay, so if we're thinking about the mild one, the heart rate will start to rise. So it may be up at the 100 to 120 beats per minute. There probably won't be a large drop in blood pressure initially because of those compensatory mechanisms that are kicking in, but we will start to see those signs of shocks. Like I've said, for example, that heart rate increase. Your pulse pressure may drop slightly. Your respiratory rate may start to go up a little bit at this point, so 20 to 30. Urine volume is going to start dropping, so 20 to 30 mils per hour. And your mental status, you may be normal, or you may be slightly mildly anxious or agitated, for example. Okay, so now let's think about moderate loss in blood. And so we're thinking, 1.5 to 2 litres or so. So again, your heart rate's going up again as we're trying to compensate for that blood loss, so 120 to 140. Blood pressure is definitely dropping now, so your systolic's going to be probably less than 90, with your pulse pressure also dropping. Respiratory rate, again, is having to go up. You've got less red blood cells, you're losing that blood. So that's going up to your 30 to 40 mark. Urine volume dropping again, becoming quite low. And now you're definitely starting to get pretty agitated and pretty confused. And finally, when we go into severe, your compensatory mechanisms really can't deal with it anymore. And so your heart rate's very, very high. So it's going above 140 beats per minute. You can't compensate. You can't get enough blood getting to the tissues. You can't feed your tissues very well. So your systolic's really dropping to less than 80 millimeters of mercury. Pulse pressure obviously is dropping. And your respiratory rate is above 35, so it's significantly high. Urine volume, very, very low indeed, because you're just not getting any blood going to the kidneys. So you're not forming any filtrate because you've got all this vasoconstriction going on all over the body, especially to those, to the tissues that really don't matter. So the skin, the skeletal muscle, and the renal system. At this point, you definitely don't need to be passing urine. You need that blood going to the heart and to the brain, for example. And again, mental status now very confused and very lethargic. Okay, so that was hypovolemic shock. Now we're going to go through cardiogenic shock. And this occurs when the pumping ability of the heart is impaired. So this might be in severe congestive heart failure, for example, or following a myocardial infarction. And it's kind of thought of as being severe cardiogenic shock if more than 40% of the left ventricle is affected. And so if more than 40% of the left ventricle is affected, obviously you get a dramatic drop in that cardiac output, can no longer pump out as much blood as you would like. It means you're getting less blood flowing to the coronary arteries as well as everywhere else. It means you're depriving the heart muscle of the oxygen that it needs, which means that you have a decrease in the pump power, which again starts to decrease that cardiac output. And you can start to see how you get this vicious cycle of a drop in cardiac output, depriving the heart muscle of oxygen, meaning the pump power goes down, which means the cardiac output also goes down. And so it can also be due to other things. So it can also be due to pericardial effusion. And this is where you're getting the buildup. So there's your pericardium. And this is where you're getting buildup of fluid in and around the pericardium. And so if the rate and the amount of effusion production is large enough, the pressure within that pericardium rises, causing impaired filling of the heart, therefore leading to reduced cardiac output. So remember, the pericardium itself, that's this thin membrane sac that covers the heart. And how much does it normally contain? Can you have a think in your mind, what does it normally contain? How much pericardial fluid does it normally have? It's somewhere around about 30 to 40 mils, and that helps to lubricate the heart's movement within the sac. So your small pericardial effusions may contain, somewhere around about the 100 mils, but these large effusions can contain over 2 liters, so huge amount of effusion there. And so what's the most common cause of it? Well, pericarditis is the most common cause of pericardial effusion, so viral infections, for example, cytomegalovirus and HIV. Others include things like cancer, injury due to a medical procedure, myocardial infarction, and bacterial infections as well. So what might that fluid effusion actually be? Well, it can be a couple of things. It can be a transudate due to hydrostatic or oncotic disturbances. It can be an exudate due to local infection and therefore inflammation, or it can be the result of hemorrhage. Remembering the differences between exudate and transudate, can you just tell yourself in your mind what that difference is, please? So your exudates will contain protein and white blood cells and some platelets, usually due to inflammation, and the transudates are caused by disturbances, like I said, of hydrostatic and oncotic pressure, but not by inflammation. So they don't have that protein content in particular. So we're just going to touch on obstructive shock now as well. And actually, obstructive shock and cardiogenic shock have much in common, and they're frequently clumped together as one. And so it occurs when the great vessels or the actual heart itself become physically blocked. And you can imagine if blood flow from the heart is reduced due to a decrease in your venous return, so that obstruction of the venous return to the heart, for example, in vena cava syndrome. Or if it is obstructed as it leaves the heart, for example, in cardiac tamponade or pulmonary embolism, then that, of course, will lead to a reduction in stroke volume and lead to a reduction in mean arterial pressure and a reduction in cardiac output. Just so that you know what both of those things are, obviously you'll know pulmonary embolism, or I hope you will. That's where you get that blockage in the arteries in the lungs that's moved from elsewhere in the body. And symptoms include things like shortness of breath, chest pain, in particular when they're breathing in and sometimes coughing up blood as well. And your cardiac tamponade, of course, that's when you're getting fluid buildup in the pericardium. Remembering that's the sac around the heart. So that's building, that fluid's building up, that starts to compress on the heart itself, meaning it can't stretch out as much, which again means that your venous return is dropped, your stretch is decreasing, and your stroke volume is decreasing as well. And so all of those things, if we're looking at that, in both cases, we're getting a reduction in the stroke volume. And if you're reducing the stroke volume, you're reducing your cardiac output. And if you're reducing your cardiac output, you're reducing your mean arterial pressure. And that's what's leading to that obstructive shock in the first place. But like I said, a lot of these are actually often categorized into that cardiogenic shock at the same time. Some places will have the 4 different types of shock. Others will lump obstructive and cardiogenic together. And what I'd really like you to do in this last little section is complete this table below, looking at the various variables: cardiac output, which we've just done, so that's an easy one, central venous pressure and systemic vascular resistance or total peripheral resistance. What will be the changes to each one in obstructive shock? Will they go up? Will they go down? Or will there be no change? So just press pause, go up, down, no change, and we'll go through it. Okay, so the first one, cardiac output. Well, we just covered that. So as you know, if you're getting a block to heart outflow or an obstruction of venous return, your heart is unable to pump as much blood out with each heartbeat. So the stroke volume goes down, meaning that the cardiac output also goes down. Now, of course, if your stroke volume is going down, so you're getting less going into that systemic circulation. Where is it? Well, it's left in the venous circulation, so your central venous pressure goes up. And what about your systemic vascular resistance? Well, of course, if you've got a reduction in cardiac output, you've got a reduction in perfusion of the tissues. So therefore, your systemic, you activate your sympathetic nervous system. It's a compensatory measure. You get this systemic vascular resistance increase as you're getting vasoconstriction. So your systemic vascular resistance goes up. So the final type of shock we're going to look into is distributive shock. And remember, this is where we're affecting the blood vessels themselves. So this can be neurogenic, anaphylactic, and vasodilatory, for example, in septic shock. And so neurogenic shock occurs due to the loss of normal basal tone in the blood vessels throughout the body. And venodilation is particularly important. Why do you think that is? Well, it's important because it leads to large volumes of blood pooling in the venous system. And remember, the venous system already has 2/3 of the total blood volume. So as the blood pools in the veins, you get a decrease in that venous return, therefore leading to that decrease in that cardiac output. And the veins are usually tonically constricted. Remember, your blood vessels have this tonic vasoconstricted state via the sympathetic nervous system. And that's the same for the veins. They're normally tonically constricted via the SNS. And of course, if that is inhibited, you get that vasodilation and then that pooling effect. So damage to the sympathetic nervous system of those veins can lead to that neurogenic shock. And so how might that occur? Well, it might be cervical or high thoracic spinal cord injury. It may be brainstem injuries. Remember, the brainstem includes the midbrain pons and medulla oblongata. General anesthetics that depress vasoconstrictor activity of the brainstem, and spinal anesthesia of sympathetic outflow are some of the examples. So anaphylactic shock is a large drop in blood pressure due to an immune reaction, and it's a hypersensitivity reaction. And that's where you get an allergic response that triggers a rapid response to an allergen. So of course, in this mechanism, and this is only a very basic mechanism for you, you get previous exposure to an allergen. That immune response generates an IgE antibody, which binds to mast cells, which then we have allergen-specific IgE attached to those mast cells. If we then get subsequent exposure to that allergen, the allergen binds to the IgE present on those mast cells, leading to your chemical secretions. And if we're thinking about in the lungs, we'd be thinking about, or in blood vessels, we'd be thinking about vasodilation. We'd be thinking about bronchoconstriction in the lungs, and we may be thinking about increases in capillary permeability, leading to edema. So this is what's happening in that kind of mechanism. So, but a binding of an allergen is normal, and it helps to serve to remove that antigen or that allergen. But that byproduct is histamine release, amongst other things. So you get histamine, you get leukotrienes, and you get prostaglandins, of course. So, and histamine is very important in fighting infections and in that inflammatory response. Can you remember just quickly what's the functions of some of the functions of histamine? So histamine induces vasodilation, it induces mucus production and endothelial gaping. And by having that increased gaping or that increase in permeability, it allows fluids and cells of the immune system to leak from the bloodstream through vessel walls and migrate to the site of injury or infection, where they can then go on to begin to fight the infection and heal the injured tissue. So that's your histamines for you. What about the leukotrienes? Can you remember what they do? So they induce smooth muscle contraction and bronchoconstriction. And last one, prostaglandins. What do? They induce pain and cause vasodilation. So that's what they are doing, and they have nice functions in the body, but in allergic reactions, the mast cells release huge amounts of these molecules, and that can lead to local effects. So in allergic reactions, if they're local, it can lead to runny nose, watery eyes, bronchoconstriction and tissue swelling. For example, the mild effects of pollen in hay fever. In anaphylactic, of course, these effects become systemic and produce mass vasodilation and capillary permeability, therefore reducing blood volume and pressure. For example, your severe effects to allergies such as your peanuts, your bee stings and penicillin, for example. And rapid treatment with adrenaline is required to help open up the airways and stimulate that vasoconstriction that is required. And of course, antihistamines and cortisone can help to further block the effects of histamine. Cortisol is anti-inflammatory as well, as you'll know. Now we'll move on to distributive shock. An example of this is septic shock, and this is where you get a large drop in blood pressure due to failure of the vascular smooth muscle to constrict. It's usually caused by extensive systemic bacterial infection. It can also follow long-lasting shock from any cause, potentially. As well as that, it's potentially caused by poisoning from carbon monoxide, nitric oxide, and cyanide. So there are other causes of it as well. And so that vasodilation caused by a number of mechanisms is thought to be, potassium channel opening and nitric oxide synthesis. So we know how vasoconstriction and vasodilation is helped to be mediated via the sympathetic nervous system, but also through nitric oxide itself. So this vasodilation, like we've said, is caused by a number of mechanisms, and one of which is the potassium channel opening in smooth muscle. So how does this work? Well, the bacteria release a variety of endotoxins. This leads over time to decreased cellular ATP levels. That means the potassium channels start to open and you get cell hyperpolarization as potassium leaks out of the cell down its concentration gradient. And so if we're just looking at this, you're seeing there's your resting membrane potential, you get your hyperpolarization, the potassium leaves the cell, so you're losing positives from the cell, so it becomes more negative inside the cell. That prevents the opening of voltage-gated calcium channels, or makes it harder to reach threshold, and you get reduced calcium, therefore reduced muscle contraction, and therefore you get your vasodilation going on. And now if we're thinking about how it works in terms of nitric oxide synthesis. So the bacteria, again, they're releasing those endotoxins. We're starting to, in this case, we're starting to stimulate our immune cells. They release a variety of cytokines, and these cytokines can start to induce nitric oxide synthase. And so therefore we're starting to make more nitric oxide, more NO. And that, of course, in itself leads to vasodilation. And it then in itself also opens up those potassium channels, which through hyperpolarization leads to that reduced muscle contraction again. So here's a kind of a summary slide showing the main causes of shock that we've already gone through. So you've got your hypovolemia, and you're thinking about your hemorrhagic shock, such as trauma, bleeding, you've got your fluid loss, your diarrhea, your vomiting, your burns, and your dehydration, all of which leads to decreased venous return, and therefore decreased cardiac output, and therefore shock, which, as it says there, is the inability of the circulation to perfuse the tissues that it needs. You've got those vascular causes that we talked about, so neurogenic, anaphylactic, and septic, leads to peripheral vasodilation, and that, of course, leads to that pooling, and you get a decreased venous return, decreased cardiac output, and shock. You've then got your cardiogenic causes, such as your heart failure, your MIs, arrhythmias, whatever it might be, leading to decreased cardiac output. And then you've actually got these other ones as well, and I did touch on them a little bit earlier. You've got some obstructive causes as well. So all of these various mechanisms can lead to that decreased cardiac output and shock. So one little last slide for you, so some review questions. So press pause, have a little bit of a read, and we'll go through them. So the first question, overwhelming infection and resulting vasodilation can lead to the following type of shock. So only one of them is correct. Is it 1, 2, 3, or 4? Well, hopefully you have put 4, so septic shock. Question 2. The acid-base balance which commonly accompanies shock is, so again, it's just one of these. Which is it? 1, 2, 3, or 4. It's a metabolic acidosis due to a lack of oxygen. So you're getting that lactic acid accumulation. Thank you very much. The end.